All right, welcome to The Explainer. Today, we're diving deep into the official battle plan for treating one of the world's most dangerous superbugs, drug-resistant tuberculosis. So what happens when our best medicines just stop working? I mean, imagine a disease that has learned how to outsmart our most powerful drugs. For millions of people, this isn't some hypothetical question. It's a life-threatening reality. Yeah, we're talking about multi-drug-resistant tuberculosis, or MDR-TB. And let me tell you, this is not your standard TB. This is a superbug, plain and simple. It doesn't respond to the usual treatments, and that means we need a whole new, sophisticated strategy to defeat it. Okay, so let's get into it. Before the fight can even begin, doctors have to do some serious intelligence gathering. It's called the pre-treatment evaluation, and honestly, it's the foundation for the entire fight. You know, this isn't just about ticking boxes. It's a critical three-step process to basically map out a patient's entire health landscape. Every single test, the blood work, the ECG, it's all vital intelligence. It's our doctors make sure the powerful drugs they're about to use are going to help, not harm. All right, so once all that intel is gathered and the patient's profile is crystal clear, doctors move to their first and most powerful line of attack, a really groundbreaking regimen known as BPALM. Now, you can see right away there are some pretty strict rules here. BPALM is an amazing weapon, for sure, but it is not for everyone. Doctors have to carefully match the treatment to the patient, making sure they have the best shot at success without taking on unnecessary risks. That's why, it's not for patients under 14 or those with serious liver problems. So what's in this powerful cocktail? It's a combination of 4 drugs, bedaquiline, pritimatid, linezolid, and moxifloxacin, that basically work together to completely overwhelm the bacteria's defenses. And to handle potential side effects like nerve damage, patients also get pyridoxine, which is just vitamin B6 as a kind of protective shield. And this is the real game changer. Just 26 weeks, we're talking about 6 months. For a disease that used to mean years of grueling treatment, a timeline this short is, well, it's absolutely revolutionary. So what happens if a patient isn't a good fit for BPLM, right? What if they're already resistant to one of the drugs or have some other condition? Well, that's where the backup plans come in. Let's look at how this whole tiered defense system works. Okay, so Plan B is a different drug cocktail. It's usually for patients who, for example, aren't resistant to a key class of antibiotics called fluoroquinolones. But there's a catch. This regimen takes a lot longer. And yeah, the commitment is way longer. We're talking 9 to 11 months of daily therapy. Now, that's a huge jump from Plan A, but believe it or not, it's still a massive improvement over the old treatments.
And then, for the most complex cases, for patients who can't take either of the shorter regimens, maybe because of really extensive drug resistance, doctors have to pull out the last line of defense.
And the duration here, it's just staggering. 18 to 20 months. This is the real marathon fight, the absolute last resort against the most stubborn versions of this superbug. So you see, this tiered system is really the heart of the whole strategy. It's not just one plan, it's a whole series of backup plans. It lets doctors tailor the attack, shifting from a short, intense fight to a longer one if they have to. The goal is to make sure every single patient has a real shot at a cure. But here's the thing, prescribing the right drugs, that's really just the beginning of the battle. The road to recovery, it's a marathon of constant monitoring and serious support. It is not a sprint. Just look at this timeline. This shows the kind of relentless follow-up needed for even the shortest regimen. It's a constant stream of checks, blood counts, heart monitors, lung scans, all to track progress and manage the pretty intense side effects of these drugs. And get this, it doesn't even stop when the treatment is over. The follow-up keeps going for another 2 years. But all the best drugs and science in the world mean nothing if the pills aren't actually taken and taken correctly. And that brings us to maybe the most critical human part of this whole fight. And look, this is not about not trusting the patient. This is pure biology. See, some of these drugs stay in your system longer than others. So if a patient misses a few doses, they could end up with just one drug left fighting the bacteria. And that is like an open invitation for the bug to learn how to beat that drug. Direct supervision makes sure the full cocktail is always at work, giving that superbug absolutely no room to evolve. So it really leaves us with this big question, right?
as the science gets better and the treatments get shorter and more effective, the final challenge is still there. It's not just about the pills in the bottle. It's about building up the human support systems, the treatment supporters, the counselors,